Welcome to an online course on special care dentistry. I am so excited that you have decided to join me today. My purpose here is to provide accurate and timely information to both dentists as well as specialists that will increase access to care for people with special healthcare needs and any related medical complexities. No part of this presentation has been sponsored by any for-profit entity. We are going to cover 6 modules in this course. The first module will focus on the foundation of special care dentistry, what it is, who these patients are. The second module will cover medical as well as dental considerations. This will be kind of the meat and potatoes of the full course. It's going to be a little extensive, and I want you to buckle up and be ready for it. Module 3 will go over behavioral guidance, communication, as well as sensory supports. I'm going to share lots of tips that I use every single day in private practice that you can start implementing on Monday. Module 4 is the most important module in this entire course. Preventative dentistry, if we don't focus on it, things for patients with special healthcare needs will really never improve. So I'll harp a little bit on this module and go over the steps that we follow in treatment planning, as well as share some treatment materials that I love using and other equipment that I absolutely recommend for everyone to have. Module 5 will cover sedation, immobilization, and hospital dentistry. A lot of you will not need to use these resources at all. If you follow steps from module 1 to module 4, you will never have to resort to module 5. Unfortunately, most of our colleagues resort to module 5 right away as soon as they see a patient with special healthcare needs that doesn't fall in a predictable bucket in the practice. And the goal of the course is really to show you lots and lots of ways in which we can help our patients avoid hospital dentistry. Module 6 is going to cover interdisciplinary care, how to work with other colleagues, other healthcare professionals in the field. We will go over team training, how to schedule these patients, what kinds of administrative workflows are required for these patients, and we will cover practice management. I know a lot of you listening to this are private practice owners, and the number one question is, how do I make this work in my busy practice? And I will show you how to make it work. Apart from seeing patients with special healthcare needs, we see a lot of neurotypical patients too, and we still make it work. So there are ways to make your day successful and productive even though you will see patients with special healthcare needs, maybe 1 or 2 of them in your day, and I will show you how to do that. Throughout the modules, I have lots of case studies from actual patients who I've seen in the last year or two, and some of them went successfully, some of them did not. Some of them required lots and lots of training, and some just surprised me by how well things proceeded even on the first visit. So I want to show you these case studies to make you aware of how well some procedures can go and how well some patients can do despite our anticipation or our fears around them. So I hope you learn a lot. I hope you're ready for the course. Let's dive in straight to module 1. We will cover the fundamentals of special care dentistry. The learning objectives here are pretty simple. We're going to define special healthcare needs. We will identify the populations that fall in this bucket. We will recognize some of the most common barriers that patients with special healthcare needs go through in order to find us. And lastly, I'll touch about why this all should matter to you, a dentist or a specialist, why you should care, and why this is super important for you. What are special healthcare needs? This definition has a lot of red in it, And it's because so many parts of this definition are so important. Special healthcare needs actually includes any physical, developmental, mental, sensory, behavioral, cognitive, or emotional impairment. So it's lots and lots of different conditions that basically require some kind of medical management, a different sort of intervention, or the use of a specialized service or program. So, what this means is that a patient could have any need that requires a different approach than what is typically offered to people. The condition could be congenital, it could be developmental, or it could have been acquired after a lot of time through some kind of disease, trauma, or environmental cause. So, what this tells us is that patients are not necessarily born with special healthcare needs. A patient could have been neurotypical their whole life, and maybe at the age of 50 or 60, now they have developed special healthcare needs and they require more accommodations and more support from us. So you might be seeing that there are patients in your practice who are only now, after 20, 30 years in private practice, they are now starting to develop some specific needs that require a little bit more effort, a little bit more time from your practice. These needs impose limitations in performing daily self-maintenance activities. Typical self-maintenance activities is transportation. Some patients require wheelchairs, or some patients require help with brushing or using the toilet or making their meals that they previously had no issues with doing by themselves. Many of these needs cause substantial limitations in major life activities. So I hope this definition is kind of bringing into your mind different kinds of people who develop special healthcare needs. Maybe a parent, maybe a close friend of yours has a special healthcare need and you just never realized it. It's very important to use person first language when referring to these patients. It's no longer okay to say special needs patient or an autistic person. You have to use person first language. What that really means is it's a patient with special healthcare needs, it's a patient with intellectual or developmental disabilities. This is just a more respectful way of addressing others. So, who are these patients? It could be a person with intellectual or developmental disabilities. It could be anyone that has a physical disability. It could also be someone on the autism spectrum, ADHD, ADD. These are kind of invisible disabilities. You will never know that a patient has these conditions unless we give them an opportunity to tell us, right? It could be someone with Down syndrome, someone with cerebral palsy, someone with dementia or Alzheimer's. It could be somebody who is medically complex. They talk the way everyone does, they look the way everyone else does, but now they have chronic medical conditions that require specific interventions. They could also have behavioral or sensory disorders. And of course, this bucket also includes our patients who are senior. Remember that this is a very small list. This does not account for everybody. What are the typical barriers to care that our patients are witnessing? They are definitely witnessing transportation barriers. They might need help getting to your practice and leaving. Once they're in your practice, they might need help being transported into the dental chair and out of the dental chair or using the restroom. Another barrier is insurance. This, I feel, is actually a much smaller barrier than what it seems. It's more a barrier for the dental office than for the patient. And I'll go over that towards the last module and kind of explain what I mean by saying that. Communication could be a barrier. Some patients are nonverbal. How do you communicate with these patients? Some of them use alternative and augmentative devices. How can we use these to communicate with our patients? Some patients have behavioral and sensory issues. What that means is maybe the light, maybe the stimulation in the dental office, having too many people around the dental office, it being so new to them, All of that could make things a little difficult for them to get care. There's also medical consults and complexities and the associated time that it takes to address these barriers. What that really means is that maybe a patient with Down syndrome has cardiac issues. And so we need to make time to consult with their cardiologist and get information from them. Perhaps there is provider availability and team willingness or cooperation. That is another barrier to care. For this patient population, there are very, very few dentists and specialists who are available to take care of them because of various reasons. And that poses another barrier. And lastly, I'm going to just touch upon caregiver burnout. Many of our patients come with caregivers. Some of these caregivers could be social workers, some of them could be family members, or they could be power of attorneys. And these caregivers might be experiencing burnouts of their own because they are taking our patients to multiple appointments in a day. They're taking care of patients with their meals, they're helping them use the toilet, they are helping them sleep, brush their teeth. And so dentistry might not be a top priority for them. Brushing their teeth daily might not be a top priority for them. We'll go over this in detail towards some of the next modules, but remember that addressing caregivers as well as their availability and their time is important for us as their dentist. So, why should all of this matter to you? You're a GP or a specialist, you have a super duper busy practice, and you don't have space to deal with all of the time and all of the effort that it might take to see these patients in practice. One of the biggest things is access to care. A lot of patients with special healthcare needs really don't have a lot of options. There's maybe a handful of practitioners who have the time and the availability to address these patients' needs. And most of the patients are actually getting pushed into hospital dentistry, putting a lot of burden on our hospital systems. Many of them have to wait a minimum of 6 months to simply get on the hospital list. When they are seen in the operating room, it is a procedure that lasts an hour. They're getting extractions done, cleanings, fillings. Are they really getting crowns? Are they really getting root canals? Not really. Some hospitals have the privileges of being able to offer those kinds of services. Most don't have that opportunity at all because they don't have same day crown systems, or they don't have residents who are able to do molar root canals in that short duration of time. So it gets really, really hard. A lot of patients who are going to be waiting for the operating room are going to have their teeth removed. And are those teeth ever going to get replaced? Are they going to get partials? Are they going to comply for partials? Are they ever going to get implants? These are questions that nobody knows the answers to, and it becomes really, really difficult on the entire healthcare system. We really need to do everything possible to prevent that from happening. There is a lot of strain on caregivers, and by caregivers, I'm only talking about the power of attorneys or family members or the social workers who are involved with these patients. Not all of them come from a situation that they have learned how to take care of people with regards to their brushing habits. Some of them need to be taught how can somebody's teeth, somebody who is going through dementia, how do their teeth need to be cleaned on a daily basis. So we need to be part of that solution. We need to be part of that educational team that is helping caregivers with this. There is a lot of provider burnout. The few dentists and specialists who are taking care of this patient population are getting extremely burnt out. And I can tell you this from personal experience. When I was in residency a few years ago, we would start to get completely exhausted by the long lists of patients who we felt would never get seen in a timely fashion. And that's very straining emotionally. It makes you want to avoid seeing these patients in practice because you feel so helpless. No matter what you do, you're just a drop in the bucket, right? So we need to help each other out and really expand access to care for these individuals. The last thing I really want to share is this is a very, very loyal and rewarding base of patients. Once you make one patient happy, they're going to stick to you no matter what. And they're going to send you all of their friends and all of their family members because they're going to be so, so, so happy with you. Patients with special healthcare needs tend to revolve in the same tight knit circles that you see in other communities. They hang out at Special Olympics, they hang out at different social work events. So things start to spread. Once you start to gain a reputation of being a dentist who is great with patients with special healthcare needs, you will start getting lots and lots of referrals, and you will thank me for that. So try and see this patient population, meet their needs, and you will always have a large number of new patients knocking on your door. I did miss talking about longer lifespan, and what that really means is that the trend for the next 10, 20 years is that people are living longer and people are starting to live with more and more chronic medical conditions. So it's not only our duty, it's we have to start learning how to care for patients that have complex medical histories because we're going to just start seeing more and more of these patients in our regular practice. So, what is our responsibility as a dentist or as a specialist seeing this patient population? We really need to be up to date on our education, not just dental, but medical as well. We have to be involved with training our team. Team training is actually super duper important. If you don't have a good team, you cannot do this alone. I will say that right away. You cannot, as a dentist with a big heart, do this by yourself. You need your team to be on board and you need to have good amount of training. And I will teach you how to go through that. You have to make your practice accessible. I know some of us have inherited really, really old practices, maybe back before ADA compliance was a thing. And so our practices are very, very small and they can't really accommodate these giant motorized wheelchairs that you now see people use. But I will show you how to get over that hump also. We have to understand what is supported decision making. So some patients with special healthcare needs need help to make their decisions. Someone with dementia, for example, who does not have a power of attorney, how do you navigate that situation? Who do you actually get permission from? Do they give you consent themselves? That is something you have to figure out before starting any kind of treatment. So we'll also go over how to navigate POA. POA is power of attorney, guardianships, conservatorships. We'll go over all of that in another module. And we have to learn what is appropriate for a patient. If someone is in advanced stage of Alzheimer's, for example, are you going to be planning for mouth rehabilitation? Are you going to be planning implants, partials? Are they going to comply for that kind of treatment? If they are on a DNR status, DNR is do not resuscitate, are you going to plan extensive treatment? It's a gray area, but we'll kind of go over that in the next few modules. And how to create timely referrals. Timely referrals doesn't just mean referring someone to hospital dentistry. It also means making referrals to a root canal specialist to complete the root canal. Will the root canal specialist be able to manage this patient's behavioral and sensory conditions? Will they be able to access them using their wheelchair? Will the wheelchair fit in their operatory? These are all things that we have to ask in advance. And another responsibility we have is to provide consistency. Patients do very, very, very well with consistency. And by consistency, I mean they know what to expect, they know who is coming to treat them, whether it's me, it's my lead assistant, or if it's a second assistant. They want to try and see the same people, and this is absolutely possible in your private practice. Not so easy in a hospital setting. This is a picture of me with my daughter at Special Olympics. We volunteer at Special Olympics every year. Special Olympics is a wonderful organization. It's very, very old, actually. It's been established several years ago, and they provide lots of resources and support to people with special healthcare needs, show them the value of being involved in sports, and also help them see the value of taking care of their health if they want to participate in sports. So there's a dental event called Special Smiles every year held right before the summer games, at least here in California. The goals of special care dentistry is to be preventative first. We are trying to educate patients on how to prevent conditions from getting worse. We need to preserve function, minimize triggers over time, and establish long term care. And these are the same goals that you would have for any other patient. Why focus on prevention? This is a picture of my husband when we were in New Zealand, and he took a dip in a lake that we later realized had some kind of bacteria in it. And we should have thought of it earlier because nobody else was swimming but him. And because it had this weird bacteria in the lake, he suffered for the next week with a weird rash. But what does that teach us? That teaches us that we should have paid attention to what could have happened. We should have read the signboards. They were all in English. We totally missed it, so that we could have prevented that issue. It's kind of the same thing, right, for patients with special healthcare needs. We're trying to kind of harp in on prevention because no matter what kind of dentistry you do, you might be doing the Taj Mahal of dentistry in these patients, but if they can't take care of it and you haven't given them the resources to take care of that dentistry at home, they are going to end up back in your chair with more cavities in a year's time. That's not fun. It's very frustrating when that happens. Remember that many of these patients are actually not candidates for sedation or hospital dentistry. What that means is maybe they're sitting in our private practice thinking, oh, this patient is exhibiting difficulty in complying with instructions or dental treatment. I'm going to make a referral to the closest hospital. They might reach the hospital, and the anesthesiologist on site will look at them, check their airway, and say, this patient is a huge risk for us to sedate, for us to put under general anesthesia. They might not make it. I'm not doing this case. I have actually heard anesthesiologists say that when I was in residency, and I realized that a lot of patients should not be given that option of hospital dentistry. So once that happens, once patients start getting declined at hospitals, they are going to jump back to you. And now you are left not only to do the dentistry, but also to manage the disappointment that the caregiver, the family, and your patient are going to be experiencing. What are the other reasons for focusing on prevention? Obviously, we want to reduce burden on hospitals. We want to reduce conditions from getting worse. I have seen time and time again a lot of patients with very simple, easily preventable issues. By the time they wait and they have time to be seen at a hospital, now those issues have become root canals and those teeth need to be extracted, which is very sad. What does work with this patient population? Again, I talked about consistency, predictability, super important. And I have a great case study to show you how that worked with one of our patients. Lots of repetition works as well. So desensitization visits are typically based on repetition, where you do 2 or 3 or 4 visits where you're kind of doing the same thing. You're building up on progress that was made at the last visit. Focus on slow progress and small wins. We are not trying to accomplish a comprehensive exam, 17 x rays, intraoral photos, a CBCT scan. a cleaning and fluoride and all of this stuff in one visit. That's a lot. Patients get extremely exhausted with so much treatment in one visit. So we're trying to focus on maybe just x-rays, maybe just a toothbrush prophy, just apply silver diamond fluoride to a few teeth that need it. We are focusing on small wins because that helps us build better rapport for the next visit where we can add more stuff. Let's end this module with a fun case study. He's one of my favorite patients, actually. A 12-year-old was referred to my practice. Heavy set male. He's very, very strong kid on the autism spectrum. So, visit one, I found out during the visit that he had visited a hospital based practice right before seeing us, where he had had a baby tooth removed with barely any anesthetic, definitely no sedation of any kind. It was a loose baby tooth, so probably the dentist kind of decided, oh, I'm just going to yank it out and it will be fine. The patient won't feel anything. But of course, he felt everything. He was extremely upset, very, very distrustful of anyone trying to do anything in his mouth. Okay, and remember, he's 12. He's a big boy. He brushes himself. He brushes his own teeth. Mom has three other kids, so she's busy. Dad goes to work. The first visit did not go well at all. We could not get x-rays, we could not get anything. He kept swatting our hands away. And when someone is swatting their hands away, we just stop. We're like, no, the patient has to decide that we are allowed to see his mouth. Only then will we go ahead and start treatment of any kind. If he's swatting his hand away, he's not in the mood, and that's okay. So at that time, I basically just had a discussion with mom, like, hey, how do his other appointments go? How does he comply with the blood draw? How does he comply with the haircut? Do you cut his hair at home? Do you get it cut by a hairdresser? All of these things give us a lot of ideas and understanding about kind of what works for him, what doesn't. Is the time of the appointment okay? Is he better in the mornings? Is he better in the evenings? And we found out something very critical. Mom was like, he does really well when his dad is around, you know. He sees dad as like this dominating figure in his life, and he does well when dad is there. So I was like, okay, let's schedule appointments when dad is there. So, visit two, we decided to come in before 10 a.m. when his dad was there. But when we went, his dad wasn't there. His dad had to leave early that day. And this stuff happens, right? This stuff happens in everyone's practice. So, how are you going to proceed from there? At this point, you have already used two visits. Do you quit? Do you refer to a pediatric dentist? Because I'm assuming that many of you listening to this are general dentists, and you could refer to a pediatric dentist. Is there any different strategy that you would try? I'm all about trying. So, we went in again. You see four visits here. There was one visit in May, there were two in September, and then the last one was in November. The second visit in September that had to be rescheduled, we actually went in and there was no one at home. So we did a visit for recently. Before I say, I need to clarify that I do portable dentistry. I do a lot of portable dentistry, which means that we go into patients' homes and offer services bedside, which really helps patients with special healthcare needs. So that's a little bit different about my practice. Visit four, how did it go? You can see we got x-rays. Are they great? Absolutely not. Is it something better than nothing? Yes. We got photos. Are they great? No. But did I get some information out of it? Yes. I can tell even by looking just at his teeth and gums, he definitely needs a cleaning, but I don't see anything crazy. I don't see like big, scary cavities that need to be addressed. I don't see that teeth need to be removed, right? At least in the information that I have, I would call it a successful appointment. What changed in this visit? Was there something different? Yes, we had a male assistant, not by design. We just happened to have a second male assistant who spoke Spanish. And my patient also spoke Spanish, and it kind of worked. Maybe it was just seeing somebody kind of like his dad, someone who was speaking in the same language as him that worked, or just the change in the team dynamics. We don't know exactly what it was, but it worked. And because of us having that male assistant there that day who spoke Spanish, things went a lot better. It was a success. So there was consistency. He also saw me and my lead assistant. We were the same people. And there was a new assistant. There was another thing that worked is you have to be a little bit flexible. Give patients more time and patience to get used to you. Family was on board with multiple attempts. That was also very nice. His mom was like, yes, let's keep trying until he cooperates. We don't mind coming back. We don't mind scheduling more appointments. And I know my screen is getting cut off here, but what I've written is the alternative is not clinically justifiable. What is the alternative? The alternative here is to send the patient to hospital dentistry, right? And what are you going to accomplish in hospital dentistry? You're basically going to send the patient in and have them clean his teeth, which doesn't make a lot of sense because this patient doesn't have cavities. There are not a lot of cavities that you can actually see. So sending somebody to hospital dentistry just for a cleaning does not make a lot of sense. Another alternative, of course, would have been to send him to a pediatric dentist, which could have worked pretty well too. So that concludes our module one. I hope you got a lot out of it and are excited and interested in continuing on to module two. Thank you so much.